Thank you, Catherine. My name is Marina Bowe. I'm a consultant general adult psychiatrist, and I'm here today to talk about my personal experience in recovery and trying to work in a recovery-focused way. I'm absolutely delighted to be joined by my colleague, Miss Margaret Sweeney. Margaret and I worked together in the RE team providing educational sessions, and I hope you will find it an enriching experience to hear the two of us working together about our personal experiences. When I think about recovery, I always find myself going back to this definition. It's the most widely quoted definition of recovery in the literature. It's an oldie, it's 1993. But it talks about recovery being a deeply personal and unique experience. It talks about a way of living a life, hopeful and contributing, even beyond the limitations caused by illness. It involves the development of new meaning and purpose. And it talks about growing beyond the catastrophic effects of mental illness. And as a psychiatrist, I meet people in crisis and in distress, and I'm sure a number of us in the room have had this experience, either a lived experience or an experience as a mental health professional sharing the journey, or perhaps a family member. And we know the reality of what mental illness can bring to a person's life, and it is catastrophic. So I think it is very, very important that we remember that. We are trying to recover, all of us together, but recover lives. And when we think about recovery, I'm a psychiatrist. I was trained as a psychiatrist. And I know the first time I was asked to go to a recovery talk and recovery education, I was a little bit indignant, and I thought, well, why do I need to go to that? Sure, that's what I do. This is really, who's telling me how to do recovery? But of course, I was completely wrong. I just didn't understand that at the time. And I'm very grateful to some of the people I worked with who dragged me to those education sessions. And I'm really pleased that they're in the room today, because my training is very much about symptoms. So someone has depression, they're feeling low, they may be feeling suicidal, they may not be leaving their house because they feel so low. So I might come and work with them, and I might treat the symptoms, and suddenly they might be saying to me, I'm feeling a lot better, I don't feel so sad anymore. And I guess I would say at that point, that's marvellous. But I might forget to ask those pertinent questions. Are you getting out of the house? What does your life look like? So when I was trained, I was thinking about a clinical recovery, which is measured by me and looking at symptoms. But actually, what's more important is a personal recovery. A life beyond illness. What does my life look like now? Because I may not feel that much better if my life doesn't look better. So when I think of recovery now, I think of recovering from the impact of the illness. And recovery for me now is rated by the service user, the person with the lived experience. That doesn't mean there's no role for what I do. I would see it very much as a partnership, so that as a doctor, I should be thinking about the combination of clinical and personal recovery. And I guess that's why I asked Margaret to join us today, because I think she can speak better to personal recovery than I can.
Thank you very much. I just want to tell you a little story about my recovery journey, so I hope it's beneficial. Life was ordinary, almost simple. Born into a family of 8 of good parents who encouraged us to reach our potential, travel, education and love were very important. I left for England at 17 years of age, where I trained as a psychiatric nurse. Like most students, I worked, partied and socialised. I met Porrick at 21, fell in love, got engaged in Paris and married him on my birthday, so he had no excuse for forgetting our anniversary. We had 2 children, Pat and Fergus, got a mortgage, bought our dream home, got a credit union loan, the car loan, living very much like most of my colleagues and friends. After 2 difficult traumatic births of my 2 children, 4 years later my life was to change. Moving back to Ireland, starting a new job, I had my first psychotic episode. This took me on a totally different path at the age of 33. For the next 6 years, my life was to be paralysed by mental illness and spiralled out of control. During this time, I was at risk of losing my children, husband, home, family, friends, colleagues. I was what you would have called in the revolving door of psychiatry. My journey took me through courtrooms, police stations, homeless B&Bs, women's refuges, solicitor's office, and in the end, a garage bedsit beside a house. I got diagnosed during this time as a persecuted paranoid psychotic schizophrenic, lost my job and had financial problems. After coming out of hospital the last time 14 years ago, I couldn't even afford a pack of cigarettes, and you know how important they are. But something else happened during that admission. I met a lovely psychiatrist who put the pen down and treated me like a human being. And my husband, who I felt I was a burden on, cried one night that he needed me. About to give up, I took notice of my life. I went home. I couldn't even clean my toilets, cook a dinner, wash the floor. The house was a disaster, with Porrick trying to work and mind 2 small kids with no family support. I reached out to a woman, a neighbour down the road, Mary, who became my sole peer support, who used the service briefly for a few months. We shared a cigarette and over many cups of tea, where I talked, rocked and shook. Mary accepted me non-judgmentally and listened to everything I had to say, and always said to me, "Come back tomorrow for another cuppa." From this friendship, I learned how to rear my boys, how to cook, clean my toilets, and how to iron a shirt. I somehow began to trust the world again and started looking outwards instead of inwards, and realised I wasn't the only one. I was, according to my nurses and doctors, maintaining very well. But after meeting the little nurse, Claire Fitzpatrick, my CPN at the time, I realised I wasn't just maintaining, I was actually recovering from trauma in my life. And she introduced me to an initiative called ARI. I began 4 years ago in Advancing Recovery in Ireland, a recovery initiative to involve and empower those affected by mental ill health. I got totally involved. I co-founded the Involvement Centre in Carlow, which is a peer-led recovery-focused space for people with mental health challenges, run by volunteers. I'm a RAP facilitator, which is a Wellness Recovery Action Plan. I also facilitate Recovery and Principles practice, which is rolled out to all staff in the mental health service. I also facilitate co-production courses and other recovery-focused courses in the Recovery College South East. Working with this nurse and the RE team and getting to know them as great friends and equal partners in the work we do has assisted me even further in my recovery journey. I'm now 20 years since my first psychotic episode. Living with my husband, we are now back on track in my dream home with my children, who have both 3rd level qualifications. One's in insurance and one's an accountant, which I'm very proud of. Recently, I won an award for volunteering in the service, and to top that, my medication is being reduced with a view to me going off it in the next 2 years. Life couldn't be better. I have a great sense of empowerment. While mental illness has shaped a small part of me, it definitely doesn't define me. Thank you very much.
Thank you very, very much, Margaret. And I think Margaret sharing her story really brings us to that personal recovery piece, and she does it so much better than me. So I'm very, very grateful for her for standing up here today and talking to us. As a doctor, What does recovery mean? How does a mental health professional think about working with personal recovery? And one of the things you heard there is the importance of hope. The hope that things will get better. And Margaret saw that in the relationship with the doctor who put down the pen. Sometimes it's very, very difficult to find hope. And we have to look hard. And we have to look back and work with the person to remind them you weren't always like this. Or perhaps more importantly, to have someone available who has lived experience. Someone who can say, I've walked in your shoes. Someone like Margaret who can tell the story of what it's really like. And I must say, my preferred piece for delivering hope is to have someone with mental health experience, lived experience, on every mental health team. And I am delighted to say we are now at a point in the country where 35 people are employed on mental health teams. And I hope days like today will generate more discussion and allow people to go back to services and demand this intervention. In practice, recovery also means talking about strengths, finding what the person is interested in, what they like to do, what are their strengths. Margaret talked about being a wife and a mother, and we could see when things were not good, Pádraig was the person who reminded her, you are a wife and a mother. So it is very important to think about, as a mental health professional, the person in the round. We also need to encourage people to look beyond services and to look at what's available in their local communities. Things like local libraries. What's going on down there? Is there some group I could join? So recovery is very much about looking outwards. I keep coming back to that phrase, it's a collaboration. It's a collaboration between the person, their support network, and the service. And I think it's very important as a doctor when I'm thinking about goals. A number of us in this room might have heard of care planning and looking at goals. But, goals are roles. What's my role in life? So saying something like reconnect the person to their family, is it not better to phrase that? Show them they're a mother, a brother, a daughter, a son. And for mental health professionals, it is vital to consider psychosocial interventions, to know what's available in your local community, to know what things help, along with your mental health training. At an organisational level, there has to be a commitment to work in this way, because it's different. And I guess I'm delighted to have the National Recovery Framework, to see all of you here in the room today, to hear Angela speak this morning, because we are getting the sense of the organisation wants to work in this way. But it's also about education and all of us understanding what this looks like, because we haven't worked in this way before. So there's education for mental health professionals, education for service users, because I've had the experience where I say to someone, well, what do you think? And they say back, but you're the doctor. And if I'm trying to say, I want you to be an active part in this process, I want you to take control, I need to explain what I'm doing. Recovery is for all. there's a lot of talk about recovery being only for adults, that it's not for children, it's not for old age, it's not for intellectual disability services or forensic services. And actually, at an organisational level, there are a number of documents looking at recovery across the subspecialties. And if we think of dementia care and thinking about a clinical recovery, well, perhaps that may not be achieved, but a personal recovery can. And it's very important that we think about personal recovery. Today we are here with ARI, which is the Irish equivalent of IMROC, implementing recovery through organisational change. You heard Gina talk about the position papers now that ARI are going to bring out. So we're going to have locally produced information. IMROC is a UK-based organisation that runs very similar to what we see in ARI. And the kind of things that might work on a bigger ticket level are things like housing first. We all know the importance of housing. It's very difficult to become well if you don't have a house. Housing First is an initiative that started in the United States and moved across. And I'm a rehabilitation psychiatrist with experience in that area. My training is around placing people maybe from acute unit, high support, down to community living. But Housing First challenges me to do something different. It challenges me to find the housing first and support the person in the housing. IPS is a similar intervention which looks at work. So instead of thinking about training and then placing, it asks us to support people in the workforce. The big thing I think that we can all know works is peer support. And it's about asking our organisations to bring this to us. Some of you will have experience of recovery colleges, and there are a number of stands here today which look at recovery colleges, and I would be encouraging you to go and look at these. But you know something? I'm a doctor and I need the evidence. And yes, the recovery evidence is different. It's mainly around personal narratives, like you've heard from Margaret. But guess what? There's some hardcore evidence as well. This is a UK-based study showing that recovery-focused practice is associated with discharge successfully from inpatient rehabilitation services. Helen Gillespie, who worked on this study, is a professor of rehabilitation psychiatry. 2 studies here looking at peer support, reducing the length of hospital admissions and supporting earlier discharge. So these are hardcore research. Those 2 initiatives I talked about, Housing First and IPS, 2 large studies. Individual placement support, the work initiative I spoke about. If we look at the UK figures, 5 to 15% of people with schizophrenia in employment. Using an IPS approach, that figure rises to 60%. Not insignificant. If you're working, you're contributing to society, you're not using mental health services because you're too busy working. So we need to be thinking about these initiatives. Again, Housing First, a study from the Mental Health Commission in Canada showing the benefits of using this approach. And I suppose we hear a lot of recovery is a new idea. Absolutely not. The York Retreat was a mental health facility that was set up in 1796. I recently was looking at some of the work around the York retreat. And what did I see? I saw respect, collaboration, partnership, finding meaningful roles. That sounds very like recovery to me. 181 years later, we have the Irish document, Vision for Change. Recovery is stamped all over Vision for Change, which is national mental health policy. And it's really nice to see it developing further now with the framework. If we look at international work, we can see recovery coming to the fore in the late 90s and coming more and more. New Zealand, Australia, the UK, Google National Mental Health Policy in any of these countries, and you will see recovery. I'm delighted to be a member of the psychiatric profession and to be a member of the Irish College of Psychiatrists. We have our own group, Refocus, which is a group of service users, family members, and psychiatrists, obviously. We work together producing our own papers and providing education for psychiatrists coming through. And it's an absolute honour to see one of my colleagues from Refocus in the audience. As I said, as Catherine mentioned, yesterday RE were working with the College of Psychiatrists who now want to produce their own position paper. And we had a very good debate and a good day's work done. So we'll be watching that space. You've already heard about the framework, you've heard about RE, and you're going to hear about the Office of Service User and Family Engagement. When I think back to 2010, when I first heard the notion of recovery, and I look at now, and I see all these people in the room, I think we can safely say recovery is coming to a service near you. The kind of things that cause concern, risk management. Recovery is not about taking risks, but recovery is about collaborating and figuring out what's the best thing for the person. And, you know, when we had the era of asylums, we spoke about it was great, everybody had somewhere to go and everybody was safe. But, you know, I wonder about the lives lost, people who didn't have opportunity to engage in personal recovery. And recovery is about working with people in a positive way to engage around how do we keep you safe, how do we work together to get well. Recovery is not about increasing the burden on carers. Recovery is about gaining independence and the person being able to live their own life, the life of their choosing. For a psychiatrist, you heard me say earlier, I'm doing it already. Guess what? I wasn't. I'm sure I still do things wrong. I'm going to be learning. Recovery is not anti-psychiatry, and I know for psychiatrists we can sometimes hear the message wrong, and I think that is why it was great to have the day yesterday. I've showed you the evidence, but perhaps the most important lesson I've learned on this journey is the most important thing is not to forget to co-produce and work with someone who has lived experience. And when I first gave this talk, we didn't have Margaret, so we're all learning. You've heard our recovery reality, and I hope today you can think about what's your recovery reality, because after all, it's about what we can collectively do to make it a reality. Thank you.